Hi everyone, happy Monday. Before we get started, please fill out the pre-session survey if you're interested in CE, CNE, and the certificate of training. We will get started right at 12, but we'll give some time to folks to fill out the pre-session survey. Okay, it's 11:59. Once again, please fill out the pre-session survey if you're interested in certificate of training, CNE, and the CE. We'll get started right at 12. Good afternoon and welcome everyone to Preventing Healthcare-Associated Infections, Central Line-Associated Bloodstream Infections. This session is brought to you by Project Firstline Rhode Island under the Rhode Island Department of Health in partnership with the CDC. I'd like to thank you all for joining me today. Before introductions, I'd like to direct your attention to the chat where you will find a link to the pre-session survey. Please take a minute to answer the survey if you haven't done so already, if you want to receive the CNE, CE, and the certificate of training. And at this time, I would like to introduce Abby Anderson, who is our Project Firstline Rhode Island Project Assistant. Abby will be posting information for you guys throughout the webinar via the chat. And Project Firstline Rhode Island team is behind the scenes in support of this webinar. Now, please, if you like, take a moment to introduce yourselves in the chat and tell us your name and where you're from. Very nice, thank you. I am very happy you guys are all here with us today. So my name is Jacob Figueroa. I'm an Infection Prevention Training Liaison for Project Firstline Rhode Island. And now I would like to introduce Dr. Kearney at this time.
Good afternoon, everyone. Thank you so much for being here. I'm Alexis Kearney. I'm a practicing emergency medicine physician and super excited to be offering this webinar for you. Please let us know if there's any questions as we go along. Me and the rest of the team will be in the background. Thanks so much.
Thank you, Dr. Kearney. So we are very excited to be with you today to present Preventing Healthcare-Associated Infections, Central Line-Associated Bloodstream Infections. This session will be an interactive one with scenarios, so please feel free to use the chat feature to share your experiences and knowledges with your colleagues. Let's begin. So here are the continuing education criteria for those of you who would like to receive the CNE credit. This session is approved for 1 contact hour. This nursing continuing professional development activity is approved by the Northeast Multi-State Division Education Unit, an accredited approver by the American Nurses Credentialing Centers Commission on Accreditation. As you can see on the screen, to receive your certificate of training, CE Dental IPC, or CEMS, you will need to complete the following: the pre-session survey, attend this live webinar, and complete the post-session survey. In addition to these 3, to receive your CNE credit, you will also need to complete the post-session quiz, which will be emailed to you along with the post-session survey. The post-session quiz is optional for all others. So here's today's agenda. We've done our welcomes and introductions. We'll go over the learning objectives for this session. We'll learn about what healthcare-associated infections are, along with defining central line-associated bloodstream infections in key terms. We'll then review infection control actions to prevent CLABSIs. Throughout this session, there will be knowledge checks and case scenarios to help put our learning into practice. And at the end, we'll have the key takeaways, end of session feedback, and the live Q&A. Here are today's learning objectives. We will understand what healthcare-associated infections are, define central line-associated bloodstream infections, or CLABSI, recognize the impact, morbidity, and mortality of CLABSIs, know the signs and symptoms of a CLABSI, and review infection prevention and control practices to prevent CLABSIs. So let's dive a little deeper in healthcare-associated infections. So here's our first knowledge check. True or false? Every day, 1 in 31 hospitalized patients gets an infection due to the care they receive. Please feel free to answer the poll. What do you guys think? So you all did great. So this is true, and it's a pretty high number. So imagine that a patient is admitted to the oncology floor to treat their newly found cancer. They're getting chemotherapy via their newly placed port, and a few days later, the patient ends up with an infection in their blood due to the mishandling of the port. The patient's immune system is weakened from both the treatment and the disease, and now the patient has an infection to try to fight off on top of it all. The infection we get from healthcare that we receive are called healthcare-associated infections, or HAI, and they are largely preventable. No matter where you are, a hospital, a long-term care facility, a dialysis center, or the doctor's office, you are at risk for healthcare-associated infections. Each day, approximately 1 in 31 hospitalized patients and 1 in 43 nursing home residents contracts at least one infection associated with the healthcare. And while much progress has been made, more needs to be done to prevent HAIs in a variety of settings. This year, it's estimated that 75,000 patients will die from an HAI. Preventing HAIs is a top priority for the CDC and its partners. And thankfully, these infections are often preventable through the infection control practices that we will learn more about today. So, the most common infections associated with healthcare include catheter-associated urinary tract infections, central line-associated bloodstream infections, surgical site infections, and ventilator-associated events. C. diff infection is another harmful illness that can develop from antibiotic use. So we have a presentation on C. diff infection, and we just had a great CAUTI presentation last month. Today, we will be talking about central line-associated bloodstream infections. So, what are central line-associated bloodstream infections, or CLABSI for short? Central line-associated bloodstream infections, or CLABSI, are a serious infection that occur when germs, usually bacteria or fungi, enter the bloodstream through a central line. These lines are often very helpful, but they carry the risk of infection when these germs grow in the line and spread to the patient's bloodstream. It is very serious, and 1 out of 4 patients who get a CLABSI die from it. The good news is that even though they are life-threatening, CLABSIs are almost completely preventable with corrective central line insertion and care practices. And here's our second knowledge check. True or false? In the United States, millions of central lines are placed every year. Feel free to answer the poll on your screen. So very nice. Overwhelmingly, you guys got this correct. And this is true. This means that there are millions of chances of getting a CLABSI every year. So before we delve into CLABSIs, let's first understand what a central line is, because then the infection control actions we'll talk about are going to make sense. So what are central venous catheters? A central venous catheter, also known as a central line, is a tube that the doctors place in a large vein in the neck, chest, groin, or arm to give fluids, blood, medications, or to perform tests. These long, flexible catheters empty out in or near the heart, allowing the catheter to give the needed treatment within seconds and reducing the need for many needle sticks. They may have 1 or more lumens or channels via which fluids like blood and medications can flow. On this image on the right, this central line has 2 lumens. And the more lumens, the more chance of infection. And at the end, they are the 2 hubs right here. There are the ends of the catheter that connect the line to the infusion. Central lines disrupt the integrity of the skin, allowing bacteria and fungi to enter. These organisms can then spread to the bloodstream. So as we now know, central line placement is a very common procedure. About 5 million people receive central lines every year. Back then, central lines were seen just in hospitals, particularly in the ICU, but increasingly, these are seen outside of the hospital setting, such as in dialysis centers, long-term care facilities, and home care. And most CLABSIs actually occur outside of the hospital setting, so this information is relevant to all of us. Because central lines come with risks, the benefit of having this procedure must outweigh the risk. This slide lists the common indications for central line use. So we have administration of caustic medications, including vasopressors and chemotherapy. These medications are medications that can harm tissues or smaller blood vessels. Then we have IV nutritional support, like total parenteral nutrition, extended course of IV antibiotics, quick delivery of large amount of fluid or blood in patients with sepsis or shock, monitoring critically ill patients, to provide venous access for placement of devices, such as an IVC filter, or when there's inadequate peripheral venous access. The first step in central line placement is confirming that the patient actually needs a central line. Having written guidelines or indications can help support clinicians when deciding when to place and also when to keep the central line. And as always, we will refer to our facility policy. So once you know that the patient needs a central line, the question then becomes which catheter meets the needs of the patient. So here we have non-tunnel catheters. And unlike tunnel catheters, non-tunnel catheter is inserted directly into the vein without passing under the skin. And on the right, we have a peripherally inserted central catheter, or PICC. A PICC is an example of a non-tunnel catheter and is placed into the vein in an arm. And on the left, we have a tunneled catheter, which passes under the skin and is placed into a vein in the chest or the neck. Providers can insert medicine right into the catheter. And on the right, we have ports, which are surgically placed under the skin. Providers insert medicines using a needle placed through the skin into the catheter. An implanted port is not as visible as a tunnel catheter, does not require as much daily care, it does not get in the way of a patient's regular activities as much as a PICC line would or a tunnel catheter might. Healthcare providers use the type that is best for each patient's care. So central lines can be placed in a variety of locations throughout the body, including the subclavian, internal jugular, femoral, or various veins in the upper extremity. There are risks and benefits to each location and must be taken into account when choosing the appropriate site. When a central line is not indicated, we have options. Alternatives to central lines include peripheral IV catheters and midline IV catheters. These are less risky for the patients. So on the left, we have peripheral IV catheter. Many of us are familiar with these. The short catheter is inserted into a superficial vein in an extremity for less than a week for IV fluids and medications. And to make insertion easier, clinicians can even use an ultrasound device to find the veins to place the catheter into. And then on the right, we have midline catheters. A midline catheter is longer than 3 inches and can stay in place up to 4 weeks. And here's a fun fact. So midline catheters are actually a type of peripheral IV catheter. There can be some confusion because they can be mistaken for a PICC, but they're indeed a peripheral IV catheter since the end of the catheter does not terminate in a large vein as defined by the CDC. So we know that CLABSIs have a high mortality rate. Avoiding placement of the central lines when not indicated makes getting to zero infections more of a reality. So one question to ask yourself is, does the patient need a central line or can a peripheral IV catheter be used instead? On this slide, we have the Michigan Appropriateness Guide for Intravascular Catheters, or MAGIC criteria. This was developed by the University of Michigan and Harvard VA. The MAGIC criteria is a tool to help make decisions about which central line to use in non-emergency settings. Now remember that each patient is different and that these are general approaches. Check with your facility to see what kind of helpful guidelines and resources they have that could help you in understanding different types of catheters for different medications, dental therapies, and patient needs. And here we have our first scenario. Let's go over it together. So Miss Bond has worsening back pain. She is admitted to the hospital unit and found to have a bone infection in her back. The infectious disease doctor recommends a total of 4 days of IV antibiotics. She is ready for discharge to a skilled rehab facility. Now question, what type of IV access should the clinical team consider to reduce CLABSI rates? So we have peripheral IV catheter, we have a PICC, and then a port. And we know that this patient needs IV antibiotics for 4 days. So which do you guys think is the most appropriate? Very good. So literally I'm seeing all A's. So we know here that this patient needs antibiotics for 4 days. A peripheral IV is good for 5 days or less. A PICC is good for long term, and a port is for even longer term. So the answer would be peripheral IV catheter. So the main consideration here for this simple exercise was length of time. The clinical team should consider using a peripheral IV catheter for short-term IV access, as it is associated with a lower risk of CLABSI compared to a central line. However, if the patient requires long-term medication or fluids that are too concentrated for peripheral veins, a central line may be necessary, and the team should take extra precautions to follow a septic technique during insertion and maintenance practices. Other pieces of information that the clinician would consider are the type of medications going through the line, because some medications are irritating to the veins, like vasopressors or chemotherapy, patient characteristics, and as well as hospital resources. So even though central lines are very helpful, they do come with a variety of risks. On the screen, we have the common complications, and collectively, these complications occur in about 5% of the cases. The risk that we'll be focusing on today is the last risk, infection risk. So as described earlier, a CLABSI stands for central line associated bloodstream infection. It's an infection that either originates from or is related to the central venous catheter. CDC's National Healthcare Safety Network defines a CLABSI as a primary bloodstream infection in a patient that had a central line within 48-hour period before the development of a bloodstream infection, and the bloodstream infection is not related to an infection at another site. And here we have another scenario. So let's use the CLABSI definition for this patient scenario. Mr. Wong is admitted to the hospital due to low blood pressure. He gets a central line placed on June 1st for cardiac monitoring and develops a fever on June 3rd. Blood cultures are drawn and they're positive for Staph aureus, and there's no other source of infection. Now, can you tell me if there's suspicion to believe that this could be a CLABSI? Please write your response in the chat. Still the blank, you're right on the money. You're the first one that said yes. I'll give you guys some more time. Very good. I like these answers. So this does meet the definition. The patient had a central line placed on June 1st. They developed a fever 2 days later on June 3rd. The patient's blood is cultured while the central line was in place, and the cultures came back positive for Staph aureus, and there's no other source of infection. So this example is to have us thinking about a patient that was admitted, they had a central line placed during their stay, and within a few days later, they developed signs of infection. So think about where could this infection have originated from? This way, we can quickly recognize the source and then get to the bottom of the infection. Great job, everyone. The epidemiology of CLABSI is changing. While we have witnessed a substantial reduction in CLABSI, in fact, there has been a 13% reduction between 2022 and 2023. Approximately 30,000 infections are reported yearly. These infections prolong hospital length of stay, increase morbidity, and raise mortality anywhere from 12 to 25%. As a matter of fact, CLABSIs actually have the highest rate of mortality out of all HAIs. Additionally, CLABSIs are pretty costly. A single case can cost as much as $48,000 or more per episode. So on this graph, we can see CLABSI data for Rhode Island using the standardized infection ratio. The standardized infection ratio, or SIR, is a summary measure used to track HAIs at the state or local level over time. SIR adjusts for various facility and patient level factors that contribute to HAI risk within each facility. So on this graph, we see that between June 2017 and December 2023, our lowest CLABSI rate was for June 2022. Since then, we have had an uptick from September 2022 to June 2023. But we are on the downtrend based on most recent data. So let's keep spreading the knowledge about infection control practices to bring CLABSIs down in Rhode Island. I know we can do it. Now let's look at 5 elements of how germs spread and how they cause infection. Think about how these elements relate to your workday and the tasks that we perform. Where do you see the possibilities of germs to spread? First, the reservoir, which is the source of the germ. This is the place where the germ lives and multiplies, like an infected person, contaminated surface, or an animal. Then the pathway, which is how the germ travels. This is the method by which the germ moves from the reservoir to a susceptible person, such as through direct contact, airborne transmission, or contaminated food. Third, the susceptible person, someone who can be infected. This is someone who is not immune to the germ and can potentially become infected. Fourth, the ability to bypass the body's defenses. This refers to the body's natural mechanism that fight off the infection, which a germ needs to bypass to cause the illness. And fifth, germ survival, the germ's ability to survive. This is the ability of the germ to stay alive outside of the body long enough to be transmitted to another person. Removing any of these elements eliminates the occurrence of an HAI. So risk factors for CLABSI can be divided into 3 categories: patient, provider, and device characteristics. Certain patient characteristics and comorbidities increase a patient's risk of getting a CLABSI. These can include if the patient is immunocompromised, if the patient has severe skin burns, if there's protein-calorie malnutrition, and if the patient has prolonged hospital stay prior to having the device placed. Next, clinician factors. Clinician characteristics are risk factors related to the insertion and maintenance practices of the central line by the healthcare professional. So for example, incomplete adherence to safe insertion practices, improper site or dressing care, and failure to remove the device that is no longer necessary have all been linked to increased risk of CLABSI. And finally, device characteristics are also risk factors that are related to central venous catheter use in insertion. So for example, the insertion of a site of a central line, the number of lumens, and the indication for use of the line can all contribute to a patient's risk for CLABSI. So these are the four routes of transmission in determining cause of CLABSI. So first, we have around the catheter. So this is when the germs from the skin migrate from the puncture site along the catheter down into the bloodstream. Second is an infection that occurs from within the catheter, such as when the catheter hub is accessed without properly disinfecting it first, and bacteria move from the healthcare worker's hands into the catheter and into the bloodstream. Third is when an infection elsewhere travels via the blood to the catheter site, such as if the patient has a UTI that has made its way into the bloodstream. In these cases, the catheter is implicated, but is not the cause of the infection. And fourth is when the infusion itself is contaminated, leading to bloodstream infection. For example, if there's an outbreak related to contaminated IV flushes or medications, this is the least common route. It's important to understand the routes of transmission of CLABSIs to better target prevention efforts. So these are the most common germs that cause CLABSIs, but of course there are more. So on the left, we have gram-positive organisms such as Staphylococcus epidermidis, Enterococcus species. In the middle, we have methicillin-resistant Staphylococcus aureus, which is another significant and commonly identified germ in CLABSI. Then we have gram-negative organisms like Klebsiella, and then we have Candida species, which are a type of fungi. By reading what these organisms are, you can see that many of these organisms live on the skin and surfaces. And for all common organisms causing CLABSIs, antimicrobial resistance is a problem. Clinical manifestations vary depending on the severity of the illness. These are the most common signs and symptoms that a patient with CLABSI can experience. So we have fevers and chills, which are the most common. You might also see redness around the central line site. And the patient may also say that there's pain or soreness around the site or when the area is touched. Patients with central lines will develop fever, chills, signs of sepsis without any obvious source of infection should be evaluated for CLABSI. CLABSIs lead to sepsis through the introduction of germs into the bloodstream. Sepsis is the body's extreme response to an infection. It is life-threatening, and without timely treatment, sepsis can cause rapid tissue damage, organ failure, and death. Over 1.7 million people in the US get diagnosed with sepsis, and 350,000 people die or move into hospice care each year. Survival depends on the quick recognition and treatment of sepsis. Your healthcare provider will decide on the best course of treatment for your infection. The treatment may involve prescribing antibiotics and removing the central line. When CLABSI is suspected, blood cultures will be drawn and antimicrobial therapy will be initiated based on the most likely organism, considering host factors and the overall clinical picture. Antimicrobial therapy can be adjusted once the antimicrobial susceptibility results are available. In many cases, a more targeted approach can be implemented. Clinicians can also make decisions to remove the central line. And here we have another scenario. Maria is admitted to the hospital with septic shock due to a perforated bowel. On day 1, an emergent femoral CVC is placed to administer life-saving medicine. On day 4, her condition stabilizes. And on day 7, she develops fever, pain, and redness at the central line insertion site. The team suspects CLABSI and treatment is started. Now, what are the risk factors for CLABSI in this scenario? Feel free to post your responses in the chat. So I'm seeing some really great responses. So let's recognize some risk factors together. As many of you have mentioned, there's the critical illness. We know that ICU patients, especially those with septic shock and other comorbidities, are more susceptible to infection. Also, there's a prolonged use of central lines. The risk of CLABSI increases with the number of days the central line is in place. So did this patient still need the central line after 4 days when her condition stabilized? And also, as some of you have mentioned, the emergency insertion, which can compromise adherence to a sterile technique. So some of you guys have mentioned the femoral site, and based on most recent research, when it comes to the femoral site, it has the same amount of infection risk as other sites, based on most recent data. Well, thank you for that, pointing that out. By recognizing and then addressing these factors, future cases of CLABSI can be significantly reduced. So great job, everyone. So now that we know about central lines, CLABSIs, and risk factors, let's learn about infection control actions to prevent CLABSI. So there are some basic practices that we need to consider when preventing central line infections, such as cleaning our hands, central line insertion and maintenance bundles, daily line necessity, teamwork, education, compliance and auditing, and patient and family education. Let's delve deeper. So cleaning our hands is one of the most important parts of CLABSI prevention. We clean our hands by using soap and water or alcohol-based hand sanitizer. By cleaning their hands, healthcare workers reduce the risk of transmission of germs to themselves and to patients with central lines that may be picked up from different tasks. So on the left, we have examples of when healthcare workers would always clean their hands. And in addition to that, when caring for central lines, appropriate times for hand hygiene include before and after touching catheter insertion sites, and before and after inserting, replacing, accessing, repairing, or dressing the intravascular catheter. Remember that gloves are never a substitute for hand hygiene. And here's a video about hand hygiene in HAIs from the Clean Hands Count campaign.
We all know about the growing threat of antimicrobial resistance and have seen the headlines about superbugs and nightmare bacteria. Unfortunately, this threat is very real. Now more than ever, it's critical that we work together to contain these drug-resistant pathogens and the infections they cause. Keeping our hands clean is one of the most important ways to prevent the spread of infections. Every time we enter the patient zone, we can get dangerous germs on our hands and spread them to ourselves or to other patients. Sometimes we don't clean our hands as often as we should, not because we mean to do harm, but because it's a daunting task. Some of us might have to do it 100 times a day. It takes dedication, mindfulness, and time. Our patients' lives depend on it. Let's applaud the efforts and improvements we've already made. Increases in hand hygiene adherence have led to decreases in healthcare-associated infections. At the same time, we know there is still room for improvement. We can all do better. Our clean hands count. Now, more than ever.
So the Clean Hands campaign has posters, pamphlets, and other resources for healthcare professionals, patients, and family members. Abby will post material in the chat about the Clean Hands Count campaign. Feel free to check them out. Thank you, Abby. So what are care bundles? A bundle is a series of evidence-based practices that, when applied at the same time, improve both the processes of care and patient outcome. First, we will go over insertion bundles or interventions when patients are first getting their lines placed, and then we will go over maintenance bundles or interventions when caring for someone with a central line. Bundling care practices together help the caregiver to remember the evidence-based practices required and to comply with the guidelines. On the following slides are common practices we will typically find in insertion and maintenance bundles. And as always, please refer to your facility policy. So first, we have hand hygiene for this insertion bundle. So we know that cleaning our hands help prevent contamination of central line sites and prevent bloodstream infections. Next, during insertion, to ensure a sterile environment, clinicians will use maximal sterile barrier precautions, which include the cap, the mask, sterile gown, sterile gloves, and sterile full body drape during the placement of the central line. Then, skin antiseptic. Chlorhexidine skin antiseptic provides better skin antisepsis than other agents. If there are no contraindications, prepare the skin with chlorhexidine 2% in 70% isopropyl alcohol. Allow the antiseptic solution time to dry completely per the manufacturer's recommendation before puncturing the site. Next, the physician will choose the best insertion site to minimize complications. So they do this by making a risk-benefit analysis as to which vein is the most appropriate for that patient, and then documenting the reason for selecting that specific vessel. And lastly, daily review of central line necessity to ensure that it's still needed. Many times, central lines remain in place simply because they provide access and because the personnel have not considered removing them. However, the risk of infection increases as the central line remains in place, and the risk of infection decreases when the line is removed. And fun fact, so this bundle approach was used in ICUs in Rhode Island hospitals between 2006 and 2008, and it showed a 72% reduction in CLABSIs. This was part of a study conducted by the Institute for Healthcare Improvement. With the success of this study, these interventions continue to be used today. And then we have central line maintenance bundles, which include the following: hand hygiene, of course. So we'll clean our hands before and after touching the catheter insertion site, and before and after inserting, replacing, accessing, or dressing the intravascular catheter. We'll also ensure that the dressing is clean, dry, and intact. If the transparent dressing is used, ensure that it's changed at least every 7 days, or if a gauze dressing is used, ensure that the dressing is changed every 48 hours. When changing the dressing, ensure that you and the patient are wearing a mask, and ensure that the site is clean with chlorhexidine-based preparation using a back and forth motion for 30 seconds, or other antiseptic solution if it's contraindicated. Next, scrub the hub. So catheter hubs, needleless connectors, and injection ports are cleaned before accessing the catheter with an antiseptic wipe following the manufacturer's recommendation, which would typically mention using a twisting motion when cleaning the site for at least 15 seconds. And now we care for the IV administration set. IV tubing for blood and TPN are replaced within 24 hours of infusion. And IV tubing now used for blood products or lipids are changed no more than every 96 hours, but at least every 7 days. And then we have removing the central line when it's no longer needed. The need for access is assessed daily to determine if the line is still indicated and documented in the medical record. And if it's not indicated, the central line is removed. Additionally, there are other interventions that could be added into the bundle depending on CLABSI numbers on the unit, patient risk factors, and feasibility. For example, chlorhexidine impregnated sponge dressings can be used. Also, a sterile, suture-free securement device to stabilize the catheter can also be used. And another intervention can be bathing the patient daily with 2% chlorhexidine. Daily review of the line necessity will prevent delays in removing the lines that are no longer needed for the care of the patient. We know that the risk of infection increases over time when the line is in, and the risk of infection decreases if the line is out. So the following are examples of reasons to remove the central line. So, is there an infection ongoing originated from the line that still remains after appropriate antimicrobial therapy has been administered? Is there a blood clot at the patient's blood vessel? Is there an occlusion in the line that remains after all unblocking methods have been tried? Has the line exceeded its recommended dwell time, and does the patient still need access? And has the patient requested the removal of the central line? And here we have another scenario. You are a home care nurse caring for Mr. James. He has a PICC placed and is due for administration of IV antibiotics in his home. Now, what steps would you follow to prevent CLABSI? Let us know what you will do in the chat. I'm getting some very nice responses. Reading scrubbing the hub, important. Hand hygiene, washing hands. Very good. So we'll perform hand hygiene before and after caring for the central line. We will wash our hands thoroughly. Additionally, we will of course use clean gloves to minimize contamination. As you guys have mentioned, scrubbing the hub, at least for 15 seconds, and letting it dry completely on its own before accessing it. Additionally, we will follow a septic technique, ensuring that the syringe and medication is sterile. We will avoid touching the exposed parts of the syringe and catheter hub. We'll also check on the dressing to make sure that it's clean, dry, and intact. If the dressing is loose, we'll change it using sterile technique, ensuring to disinfect the skin around the insertion site with an antiseptic. We'll, of course, document care. We'll document the IV antibiotic administered, any care provided, and confirmation that the central line dressing is clean, dry, and intact. Additionally, we'll perform patient and family education, which is super important. We'll educate on hand hygiene, the signs and symptoms of infection, who to contact, and considerations of living with a pig, like, for example, making sure that it's fully covered when taking a shower so that it doesn't get wet. By following these simple steps, both the home care nurse and the patient will minimize the risk of introducing germs into the bloodstream and reducing the risk of CLABSI. Very nice job, everyone. Next, we'll go over what the facility can do to prevent CLABSI. A multidisciplinary round is when members of the team caring for the patient come together, offer their expertise, and talk about goals and progressions of care. Rounding can look different depending on the setting. In an ICU, for example, it can be a large group performing rounds at a predetermined time with a designated team leader. And on a med-surg floor, it could be the patient's nurse, the charge nurse, the case manager, and the caring physician. These rounds are a great time to discuss central line use, determine the goals for each individual patient, and identify risks associated with keeping the lines in. Rounds are also a chance to provide teaching opportunities for healthcare personnel in training. This is a time when you can discuss what in the protocol is working and which parts of the protocol need improvement. At the end of the day, we can discuss identifying and removing any central lines that are no longer necessary during multidisciplinary rounds. CLABSIs and central line utilizations are reported for reimbursement. Leadership is often interested in CLABSI data, but is this information reaching those who are directly responsible for the insertion and care of the lines? Think of the best way to share this information. Sharing unit results help build team culture and empower ownership. When events like infections are presented, specifics should be conveyed in a deeper dive root cause analysis. It's also best to discuss events as they occur, preferably in real time when it's fresh in everyone's minds. It's important that the clinical staff be aware of these metrics. They should understand how their work impacts care and make the connection between their actions and the patient outcomes. To keep the lines of communications open, encourage a team atmosphere. Ask, how will we prevent the next CLABSI, or how can we work together to remove central lines promptly? Make sure that you offer potential solutions on the next infection that can be prevented, alternatives to decreasing central line use, and promote communication between all involved in the care. Staff should be trained upon hire, periodically, annually, and as needed. We want to educate the staff regarding the indications for catheter use, procedures for insertion and maintenance, and appropriate measures to prevent infection. We will also routinely assess adherence to guidelines for insertion and maintenance of central lines. We want to provide adequate training for those inserting and caring for the central lines, which can include providing direct feedback using checklists to ensure that all the steps are being followed. Care bundles and checklists can be very helpful in this. We know that bundles are evidence-based practices when implemented together that can really bring down infection rates, while having checklists help us remember all the steps that we need to follow. A method of documenting staff competency should also be developed and maintained. Simulations-based trainings can be instituted at facilities to help with competency. Another idea is to perform direct patient care audits. These audits on the units could be during patient care, could be done by both the nursing leaders and even peers during designated times. Direct feedback on the performance should be given on personnel with the intention to maintain the safest environment possible for the patients. Auditing for adherence of central lines maintenance metrics help unit leaders also pinpoint educational needs. Now, Our job is not complete without educating our patients and their caregivers. We want to educate them on the need for the central line, the length of time the central line will be in place, making sure that the central line or site do not get wet, and to pay attention to the bandage and the area around it. If the bandage comes off or if the bandage or the area around it are wet and dirty, to tell the healthcare worker right away. Additionally, we'll educate on the importance of washing hands, when to wash hands, and also how. Let them know that it's also okay to remind the clinical staff to wash their hands before and after working with the patient. I know that we don't mind at all. And also to avoid touching the tubing, and also to avoid touching where it exits the skin as much as possible. Do not let any visitors touch the catheter or tubing as well. And of course, we'll educate on the signs and symptoms of CLABSI. We'll remind them to tell a healthcare worker if the area around the catheter is sore or red, and if you have any fevers or chills. If you have any symptoms or signs of infection, or if there are any other catheter problems, to call your healthcare provider right away. Informed patients and families are more likely to participate in their care and also to support prevention efforts. And here is our final scenario. Let's tie it all together. You are the infection control nurse at a long-term care facility. CLABSI rates at the facility are typically low. However, you notice that in Q4 of 2024, the rates went up. Now, how would you help prevent CLABSIs at your facility? Please feel free to put your ideas in the chat. Let's tie it all together. Very nice, Joanna. I'm seeing education, education, education. Good response. Audits, absolutely. So you guys are right on the money with this one. So of course, like Joanne said, we'll perform staff training, regular training sessions for healthcare staff on CLABSI prevention, onboarding training, of course, and the topics could include, when to perform hand hygiene, aseptic technique, signs and symptoms of CLABSI, and also the importance of following recommended centralized maintenance practices, which are typically part of a bundle. Additionally, we'll track CLABSI rates and perform some analytics. You want to collect and analyze data on infection rates to identify trends and areas of improvements. I also read compliance. We're thinking about that as well. We want to perform routine audits of staff adherence to hand hygiene, accepted technique, and bundle protocols. And of course, we want to provide feedback, share the results with the staff and leadership to foster accountability and improve compliance. Another very important aspect is collaborating with the multidisciplinary team to address gaps in care. Additionally, as an infection control leader, you also want to look at the policies. You want to develop and update policies to align with the latest evidence-based practices. And of course, patient education. You want to educate the patients and their families about the importance of maintaining cleanliness around the central line, hand hygiene, signs and symptoms of CLABSI, and also how to report too if there are any complications. So very nice job at putting it all together. You all did amazing. You are all, excellent infection preventionists ready to tackle CLABSI and bring rates further down in Rhode Island. I had a great time, and I know you guys all did too. So here are the key takeaways. CLABSI occurs when germs enter the bloodstream through a central line. And despite progress, CLABSI remains a costly, morbid, and lethal condition. And out of all HAIs, CLABSIs actually cause the highest number of deaths. But thankfully, they are preventable. Adhering to infection control practices reduce the incidence of CLABSI. Now, I would like to remind everyone that there are a few requirements to receive your certificate of training. To receive the certificate of training, you must complete the pre-session survey, participate in today's session, and also complete the post-session survey. A link to the post-session survey will be sent to you via email tomorrow, February 11th, and will be available until the 17th at midnight. And once you complete the requirements, the certificate of training will be emailed in PDF on Thursday, February the 20th. For EMS and dental providers, this can be used towards 1 hour of continuing education. And also, please be sure that if you're looking to receive the CNE credit, that you complete the pre- and post-session survey along with the post-session quiz that will be emailed tomorrow. The post-session training resources and this PowerPoint will be emailed this afternoon for all of those who attended today's session. Next month, we are presenting our final 2 sessions on HAI series. On March 10th, we have ventilator-associated events presented by my colleague, Lisa Ledoux. And on March 24, we have surgical site infections presented by my colleague, Stephanie Doyle. We are super excited about these 2 sessions. Abby will share the link on the chat. Please spread widely. And also, please feel free to enter your email in the chat box if you want to be added to our distribution list for upcoming trainings. You can also click on a live events link on our website. Abby will post that information in the chat as well. You can also follow Project Firstline on YouTube, Twitter, Facebook, Instagram, and LinkedIn. And here are the references for today's presentation. Now, I invite you to please take the 3-question poll on your screen. This helps us improve future sessions. I will give you a moment at the end of the session feedback, and then we will head over to our Q&A. Thank you very much. I appreciate it. And now we are at a live Q&A. We are happy to answer the questions that you have. You can put them in the Q&A box, and we're happy to answer them.
Jacob, I'm not seeing anything come through the Q&A box, except for a question about the presentation, and that'll be sent out, as Jacob said. If anyone has any questions kind of moving forward or needs help in their particular facilities, please do not hesitate to reach out to us. We're happy to do in-person training and give any assistance that we might be able to do.
Also, I actually just saw one quick question in the chat. All right, so I had a blast. Thank you so much for accompanying me to learn about CLABSI, and I hope you guys have a great rest of your day. Thank you so much. Take care.